Good evening, everyone, and thank you for joining us. I'm Dan Faulkner, Registrar and CEO of the Royal College of Dental Surgeons of Ontario, and I'm very pleased to welcome you to today's RCDSO Connect session focused on our record-keeping guidelines. This session has been approved for 2 Category 1 continuing education points. To be eligible for a CE certificate, participants must attend at least 75 minutes of the session. As always, there's no action required on your part. Our quality team will send you your certificate to the email used to register within 5 business days following today's session. Record keeping is a foundational element of safe, ethical, and high-quality dental care. A patient's chart tells their story, from medical and dental history to diagnosis, treatment planning, consent, progress notes, and referrals. Accurate and complete documentation is not simply an administrative task. It is part of patient care, a professional responsibility, and a regulatory requirement. Today's session is designed to provide a practical introduction to the core components of compliant patient records and the key principles that support accountability, continuity of care, and patient trust. Before we start our discussion, I'd like to recognize the privilege of gathering online this evening by sharing a land acknowledgement. The RCDSO is on the traditional lands of the Mississaugas of the Credit, the Anishinaabe, the Haudenosaunee, and the Huron-Wendat peoples. These traditional lands are known to some as Toronto. Toronto is covered by Treaty 13 with the Mississaugas of the Credit and is home to many diverse First Nations, Inuit, and Métis peoples from across Turtle Island. This land is also part of the Dish with One Spoon territory, a treaty between allied nations to peaceably share and care for this land. We accept our responsibility to each other and this land we live and work on in a spirit of peace, friendship, and respect. We're committed to actively supporting the necessary work towards truth, reconciliation, and equity. We embrace our role in regulating dentists, in protecting the public interest, and strengthening our partnerships with Indigenous communities to advance access to safe and equitable oral health care. Thank you. We are so pleased today to welcome Dr. Kalyani Baldoda and Dr. Peter McDermott, who will be leading today's session. Dr. Baldoda is a dental consultant for the Royal College of Dental Surgeons of Ontario, Professional Conduct and Regulatory Affairs. She holds a specialty in dental public health, is a fellow of the Royal College of Dentists of Canada, and the current chief examiner for the fellowship exams for dental public health. She conducts regulatory investigations with a focus on compliance with the college's standards of practice and relevant legislation. She has previously worked as a manager for Toronto Public Health Dental Services and as a senior health information advisor for the Ontario Ministry of Health. Dr. McDermott is an assistant professor and assistant director of quality improvement at the Schulich School of Medicine and Dentistry. He teaches patient assessment and oral diagnosis and serves as a consultant in the RCDSO Quality Department, contributing to the development and delivery of CE courses for the college. Dr. McDermott earned his DDS from the University of Toronto in 1992 and completed a Master of Science in Prosthodontics in 2005. He operated a prosthodontics practice in Grimsby, Ontario, and has held academic appointments at both the University of Toronto and Western University. His extensive clinical, academic, and regulatory experience uniquely positions him to guide dentists through the essential components of high-quality, compliant documentation. With that, thank you again for joining us for this important session. I'll now turn things over to Dr. Baldoda and Dr. McDermott to begin today's presentation.
Thank you, Dan, and thank you again for allowing me to participate. It's been a quite pleasure and honor for me to work with the college. The course we're presenting today is an introduction to the RCDSO record-keeping guidelines. There is a second course, which is a fundamentals course and a co-course applied record-keeping, which are Category 1 courses. And if you find this course interesting, you may wish to enroll in one of those, in both of those courses. We have no proprietary financial or other personal interests or relationships relevant to this presentation that could give rise to a conflict of interest. All images included in this presentation were obtained via the public domain unless otherwise referenced. The learning objectives of the course is to identify the fundamental components of a patient record as required under the RCDSO record-keeping guidelines. Our goal is that you will be able to explain the purpose and the importance of accurate, complete, and timely documentation in supporting patient care, professional accountability, and regulatory compliance. We want you to be able to recognize common documentation deficiencies and outline key considerations when maintaining patient confidentiality, privacy, and the proper management of records in accordance with the guidelines. So we'll begin with the principles of record keeping. This is a slide that you will see in many of the RCDSO fundamentals and applied record keeping courses. It breaks down the different components of diagnosis and record keeping into 6 categories: case history, clinical exam and diagnosis, treatment plan, consent to treatment, progress notes, and referral documentation. As Dan mentioned, record keeping is a critical component of safe patient care. And it's important to understand that practicing to the standard of care includes documenting to the standard of care. Dentists have a professional, legal, and ethical responsibility to maintain a complete record of every patient's dental care. It needs to be clear, accurate, and up to date, and is essential to the delivery of high quality care and for safe patient care. We need to understand that care is not complete until the documentation is complete, and failure to meet the standard of care could result in an action of professional misconduct for the purpose of clauses 51, 1C of the Health Professions Procedural Code, Section 25, failing to keep records as required by the regulations, and more serious, well, or equally as serious, falsifying a record relating to a member's practice. We will begin with the case history. So what should be included in the documentation of the case history? We never want to treat a stranger. We need to know who our patient is and what is motivating them and what are their chief concerns. So it begins with identifying the chief complaint, the reason why they're visiting, and the history of the chief complaint. It's an opportunity to get to know our patient and to understand what's important to them in terms of their care. It's absolutely essential to have a thorough and complete medical history. And we need to explore the patient's dental history to understand what's motivating them to see us, what's motivating them in terms of their care, what's important to them in terms of their care, but also those factors, those patient modifiers that have led them to the situation they're in. We'll start with the medical history. The goal of the medical history is to determine the medical risk and be able to plan for an emergency. When you know that a patient is attending for an appointment, if they have some component of their medical history that could result in an event in the practice, you want to be fully prepared to manage that event. It helps determine the medical risk and to plan for medical emergencies. We want to take a good history, including screening for blood pressure, to be a good partner in community care. We have the opportunity to see patients much more frequently than their family practitioner. And we have an opportunity to screen and refer to the physician when necessary. We want to be able to recognize some of the patient modifiers that may have impacted on their attendance for care or have kept them away from attending for regular care. We want to recognize anxiety or other patient modifiers that are going to impact in some way on our treatment plan. Most importantly, we take a good medical history to ensure safe dental care. It is the responsibility of the treating dentist to ensure that there is an accurate and complete medical history. You may be using a medical history questionnaire in your office, and that data may be collected by another member of the team. But it is your responsibility as the most responsible dentist, as the dentist who is treating the patient, to ensure the medical history is complete and up to date. It's when you, and we'll talk about this in a minute, when you identify incomplete or a vague response on a form, then it's important that you ask the appropriate follow-up questions and review of systems when necessary. So we need to ensure that it is thorough, complete, and has sufficient detail for the level of care that we're going to provide. I mentioned the appropriate follow-up questions, including a review of systems. And when necessary, we need to consult with a physician or other relevant healthcare clinicians as needed. It must always be signed, whether it's e-signed or in ink, and that should include the date as well. This is one of the more common errors during investigations where medical histories are not signed by the dentist. And of course, it must be updated on a regular basis. This is an example of the college's medical history questionnaire. You are certainly welcome to use it, or you may modify it accordingly. The important thing is that you collect all of the relevant data. And as I mentioned, the patient may, on this form, identify a drug that they're taking, but they may not identify the reason for it, or they may give partial or incomplete information. It's important that you review it in detail and you ask any additional questions or review of systems as appropriate to ensure you have a complete medical history and can provide safe dental care. In this example, we've circled a drug that the patient is on, and this drug puts them at risk for mirage and would need to be taken into consideration when you were planning extractions, implant therapy. So the patient may not entirely understand why they're on a drug. They may not understand the risks, but it's our responsibility to be aware of them and to explain to the patient why a complete medical history is important. In addition to a thorough medical history, it's important that we understand the patient modifiers that have brought the patient to this situation. We need to take a thorough dental history. We want to understand what is important to the patient about their oral health. What are the most important qualities of a dental practice for the patient? What are they looking for? How do they choose your office? What are their expectations? And you want to know how you can best accommodate the patient's needs. If they have anxiety, then you want to be able to implement a stress reduction protocol to help the patient be as relaxed and reduce the anxiety as much as possible. You want to be able to identify a patient with a disability and to ensure that you can accommodate that disability within the practice. In most situations, your practice will have already be set up for those situations, but there may be there may be opportunities to make changes, small changes, in order to accommodate the patient. So we would like to know, how can we do that in the most efficient manner? We need to identify any barriers to care. That those may be communication barriers or financial barriers. You want to ask open-ended questions about, is there anything that we can do? Is there anything in the past medical history that we need to know in order to ensure the best and safest care possible? And we want to know how can our offices help to achieve the oral health priorities of the patient and their treatment expectations. I've been discussing patient modifiers, and there's a whole bunch of things that could be involved in this situation. Do they have anxiety or fear of dentistry? Do they have parafunction or bruxism? Is there any particular interest they have in their oral health? What is their caries risk assessment? Are there things that we can help modify to reduce that risk assessment? Are there other factors such as smoking, recreational drugs? What is their compliance, their ability to perform oral hygiene and their ongoing care? And what is their ability to afford care? All of these patient modifiers identify the unique patient that we have in this situation. And we need to take into consideration those patient modifiers when we're putting together a treatment plan. In many cases, these patient modifiers will increase the complexity of care. So a moderately difficult case can be much more complicated when we take these modifiers into consideration. The dental history helps us in our risk assessment. It informs us as to the required images, radiographs that we're going to take, and the frequency for those radiographs. It helps us guide and educate the patient in terms of their oral hygiene regime. What is the best preventative regime for this patient? What should be the frequency of our recalls? And of course, these patient modifiers need to be taken into consideration when we put together a treatment plan. Controlling the patient modifiers will increase the prognosis of our overall treatment. We're going to move on to clinical exam and diagnosis. And the clinical exam begins when the patient enters the operatory. We want to take a general survey, observe the patient's gait. The more observant we are, the more clues we'll have. You want to understand their mobility, their ability to sit in the chair, the position the chair that we're going, the position we're going to have the chair in. How far can we recline the chair? We look at limbs and extremities. We pay special attention to the head and neck. We need to do an extraoral exam that includes the lymph nodes, muscles of mastication, the TMJ, and the salivary glands. When we begin the intraoral evaluation, we need to assess and document our findings. We are looking for variations of normal. We are looking for things that are not normal. We want to be thorough in terms of examining the lips and labia mucosa, the buccal and vestibular mucosa, the hard and soft palate, the oral pharynx, the tongue, the floor of the mouth, any edentulous areas. We're looking for lumps and bumps and things that don't belong. We are looking for pathology that may put the patient at higher risk. We also need to examine the hard tissue, the bone structure, any abnormalities, the ridge form, and the presence of tori or exostosis. These factors may influence or affect our planned prosthodontic options. An evaluation of the dentition needs to be thorough and complete. We want to identify any missing teeth, the existing restorations, any abrasion, erosion, abfraction, caries. We're looking at the materials that the patient has been restored with. Have there been any root canal has there been any root canal therapy, any apical lesions, or tooth positions. Good documentation may assist in the situation that it's necessary to identify a patient. Sorry, something moved ahead here. Let me just get back. We need to be thorough in this because what we are doing is we're documenting how the patient comes to see us at our first appointment. And we want to ensure that the patient improves from the first time they see us. It's important that we document the occlusion. And this is another area where there is often missing elements in a chart. The angle classification, the overbite, overjet, crowding, crossbite, other details such as whether there's canine guidance or group function. We want to look at the excursions as well. This is an example of an electronic dental chart. You can document either an electronic dental chart or paper records. The most important thing is that you never alter the chart. It must remain documentation of how the patient first arrived in the office. There should be no changes made from the original chart. In addition to completing thoroughly the odontogram, we want to record the health of the gingiva and the periodontium. You should identify the appearance of the gingiva, the oral hygiene status, the presence of plaque and calculus, any mobilities or furcations, and the probing results. Many offices will do full mouth probing. It is also appropriate to use the periodontal screening record, but you must understand that if you're using the PSR, the periodontal screening record, you must understand what it means and when it's necessary to do full mouth probing. Full mouth probing will always give you the most information. This is an example of a periodontal chart. And again, it's an electronic chart. It's perfectly appropriate to use a paper chart. What is most important is that you are thorough and complete in collecting the information and analyzing the information as part of coming to your diagnosis. We always do a complete exam before we prescribe any radiographs. We want to ensure that the radiographs we prescribe either confirm or deny a question that we have. So from our diagnostic records, we'll identify a situation that we need or we feel that a radiograph will be appropriate to help us to come to the appropriate diagnosis. We do this in terms of the ALARA principle, as low a dose as reasonably achievable. It's important to understand that there's not only a financial cost to the patient when we order tests and radiographs, but also they're being exposed to ionizing radiation, and we want to minimize that at every opportunity. So the basic principles: every radiograph should have a justification. It should be patient-specific. And ideally, you should have an understanding of what you need from that additional test in order to make your diagnosis. There is no routine prescription of a panoramic radiograph, for example, every 3 years. That would be an unnecessary exposure to ionizing radiation. We want to optimize all the radiographs we take. If we have access to previous radiographs, we should ask the question, do those radiographs answer the question? Do they give us enough information? And if not, what is the most appropriate radiograph to get that information? And where possible, we would like to limit the dose of ionizing radiation the patient's exposed to. And if you are re-equipping an office or putting in new X-ray equipment, consider the rectangular collimation. It will significantly reduce the patient's exposure to ionizing radiation. So again, I'm just going to remind you that radiographs are always prescribed after the clinical exam and the risk assessment has been done. We need to have a rationale for every radiograph that we take. So the summary slide, the radiographs are always prescribed after a clinical exam and risk assessment. The dentist must use the clinical judgment on the type, the number, and the frequency of the radiographs on a case-by-case basis, and any plans for reassessment. If there's a lesion or something that needs to be followed up, then that should also be part of our treatment plan to know, and the patient should be aware of when that radiograph may be repeated and why. It's important that you convey the information and the diagnosis, the information obtained from the radiographs and the diagnosis to the patient. And if you have paper records, whether it's paper or electronic records, it needs to be in the chart and signed either by ink or the e-signature with the chart. Again, a reminder that radiographs should not be routinely scheduled at a set time period or for routine screening. We need to have a clinical justification for all the radiographs that we order. When we make radiographs, we want to ensure that our images are of diagnostic quality. And in some cases, we're going to have less than perfect images. What we need to do is look at the image and determine whether there's sufficient diagnostic information before we choose to take a new radiograph. If you are taking a master cone file with root canal therapy and there's a cone cut and the crown has been cut off, well, the important part is the position of the cone in the canal and its proximity to the apex. There's no need to retake that radiograph. All radiographs must be dated, properly associated to the correct patient. There must be an interpretation diagnosis documented in the chart. This is a very common error and oversight. So I want to absolutely stress the importance that we'll look at records and we'll say 2 bite wings taken, but there are no findings from the radiograph recorded. If everything is within normal limits, then it would be appropriate to say that the bone level is within normal limits. There's no caries or no significant findings, but there needs to be documentation and interpretation in the records. This is a checklist, and you may want to take a screenshot or take a photograph of this. It does summarize all of the elements that we want to have in a good and thorough clinical exam. So we would have the medical and dental history first. In terms of the clinical exam, ideally we're going to screen the patient by taking vital signs, an extraoral and intraoral exam, the examination of the dentition for the odontogram, ideally full mouth probing or at a minimum a PSR for the periodontal evaluation. And again, if you use the PSR, then please be sure that if it triggers the need for the full mouth probing of a sextant or of the entire dentition, then that needs to be done. And we need to have an evaluation of any oral appliances the patient may have. Once we have that information, we have the ability to prescribe the appropriate radiographs. And of course, they must be interpreted and documented in the chart. For all treatment, we must have a diagnosis, and a prognosis should be conveyed to the patient as well. We'll move on to the treatment plan. When we're putting together a treatment plan, we should be taking all of the patient modifiers and the medical history into consideration. My mentor, George Zarb, would always say that we should be looking at the most conservative, least invasive treatment options first. All of our treatment plans should be sensible and defensible. We want to look at local issues in terms of the prognosis of individual teeth, but also global. How does that tooth fit within the overall arch? What are the overall treatment goals? So we need to take into considerations, particularly now that dentistry is expensive and there may be involved multiple appointments. What is the value, the strategic value of that tooth in the overall dentition? And this needs to be discussed with the patient. Caliani will do that as part of consent to treatment. We need to take into consideration, can I versus should I? You need to show good judgment in when you choose to treat and good judgment in when you choose to refer to a specialist. You always want to ask yourself the question, is this in the best interest of the patient? You may have the skills. You may have the skills, but for that particular patient, it may be more difficult. And you might decide, either for medical history or because of other patient modifiers, anxiety, the patient may have some restricted mobility or may not be able to be reclined as far as possible. There'll be situations where it's going to be in the best interest of the patient to refer to a specialist. Treatment plans should be patient specific. There shouldn't be a standard treatment plan for any particular clinical problem. All of our treatment plans should be based upon the data that we have accumulated and taken into consideration the patient modifiers. We want to avoid overtreatment and undertreatment. Wherever possible, our treatment should be evidence-based. We have to remember that these are our patients and that they deserve the best and the safest treatment that we can provide. It is not appropriate to use experimental techniques or new techniques that are not evidence. Where there is not evidence to support that treatment. Where possible, we should be conservative and minimally invasive. So if we have E1 or E2 and some D1 lesions in patients with low or moderate caries risk, we may choose to observe those rather than put a burr to the tooth. It's important that we have appropriate phasing and sequencing of our treatment plans. And we need to understand the etiology, the risk factors, because they're going to impact on the prognosis for our patient. Most importantly, we need to have careful documentation, especially when a diagnosis is not obvious. At that point, you need to be able to have a differential diagnosis and a plan to investigate further to come to the appropriate documentation. We always need to keep in mind that things are going to change. Doesn't happen all the time, but when it happens, we need to be able to respond appropriately. As treatment progresses, and if something changes, it may be an unintended adverse outcome, we need to be able to advise the patient, to explain to the patient what the consequences of that outcome is, how that is going to change the treatment plan, and we need to get consent for those changes to the treatment plan. Just as a reminder, it's when something happens, we have a duty to explain to the patient what has happened. And to ensure that they understand that there's going to be a need for a change or a revision to the treatment plan. Where possible, these factors should be discussed with the patient in advance. So for example, if a patient needs root canal therapy, there is a possibility of a failure, separated instrument, or a perforation, and the patient needs to be advised. Caliani will go into this in detail as part of the consent to treatment process, that these outcomes are a possibility. If the patient understands the risks, then when something happens, they're likely to be more understanding and accepting. If these events occur without the patient being informed, then the patient may feel that you're making an excuse. So we want to have well-educated patients and very, very good consent to treatment in all our treatment. Of course, any changes to the original treatment plan should be clearly documented, along with the reasons for making these changes, such as a change in the diagnosis or a patient preference. I usually mention once or twice when we do the full presentation that this is a little bit like grade 12 math. You don't get full marks unless you show your work. So our careful documentation is demonstrating all of the work involved in coming to the final answer in mathematics. When we break our treatment down into stages, it's often easier to understand the treatment plan and the treatment goals. It's easier for us to come to a full list of treatment options for the patient. And it's also easier for the patient to understand why things are happening in that order. When I'm talking to the dental students, I always point out that a patient may come with a chief complaint, but before that chief complaint can be addressed, we need to get through different stages of treatment. Before we are going to do aesthetic restorations in the anterior zone, we need to have disease control completed. The patient will often wonder why they're coming for 2 or 3 appointments and their chief complaint hasn't been addressed yet. So having them well informed and understanding of the stage of treatment that this is going to be addressed with, and also how many appointments it's going to get to there is very, very helpful. When we take a thorough and complete medical history, we may have some questions that we have to consult with the physician or another healthcare provider. These are things that we do in the systemic phase of treatment. It's an important phase because this is the phase that we ensure the provision of safe dental care. The next phase of treatment is the urgent care phase. During this time, we are dealing with clinical situations. Oftentimes, it's a chief complaint that needs to be dealt with in a timely or relatively urgent appointment. I always teach the dental students that any dental appointment can turn into an urgent care. And today, I had a student pair that was planning to do their first initial exam on a patient, and the patient had 10 out of 10 pain on a tooth. And this appointment, rather than being a complete exam of the patient's dentition, was a limited exam and diagnosis of a tooth with irreversible pulpitis. And we initiated root canal endodontic treatment at that appointment. So things can change. We can plan for one thing, but we have to remember that it is a patient, and if they have urgent concerns, we need to address that in a timely manner. Probably the most important phase of treatment we do is the disease control phase. It's often non-urgent. We do much definitive treatment during this phase, and it is our preventive care. It includes sanitary therapy, OHI, and fluoride, restorations, extractions, endodontics, and other treatment. During this time, we are taking into consideration the patient modifiers and looking at behavioral changes that we can make. Because again, I say to the dental students, there may be a patient who comes in who has uh, significant periodontal issues, poor oral hygiene, plaque and calculus everywhere, multiple caries, and they may be saying, "Hey, doc, everybody in my family has dentures, take my teeth out." But we know the biologic cost to the patient. And by educating that patient, improving their oral hygiene, addressing the caries, we may be able to motivate that patient to have much greater interest in their own oral health care. And that same patient is a different person when you get to the reevaluation stage. They're now highly motivated. They understand the strategic value of their remaining teeth, and they are much more motivated to continue their care and preserve the remaining teeth. It is a very important role that we play in dentistry. Once we finish the disease control phase, we have the reevaluation phase. And at this point, we want to know, how has the patient responded to the care we've been providing? How have they responded to the oral hygiene instruction? Have they made changes in their diet? Have we been able to address any of these patient modifiers? Reevaluation is often not a entirely separate phase. It's something that we're doing all the time during disease control. And our actual reevaluation appointment might be at the last restorative appointment, or certainly during the periodontal reevaluation. We want to look globally at every opportunity we have. After that, I have these divided separately as the definitive or pre-prosthetic phase. Oftentimes it's lumped together as the prosthetic phase. I like to separate the two of them because we're looking at this point as, does the patient require further periodontal treatment? Are there periodontal services that we can offer to the patient that's going to improve their overall prognosis? We may need to do pre-prosthetic orthodontic treatment in order to set things up for so that we can do our very best during the prosthetic phase. And there are other treatments, modalities that can fall in this phase. Once we've changed the biology in the mouth, we have motivated a patient, we have set things up for our prosthetic phase, then we can get to my favorite part, the prosthetic treatment, and that might be fixed removable implant or combinations of any of those. And this is where we have the opportunity to restore form and function and improve the quality of life for our patients, building on what we've already accomplished in the definitive or pre-prosthetic phase. Very important in all of our treatment plans is we need to be talking to the patient about what is the ongoing maintenance for our patients. They need to understand that it's not just simply we fix their teeth and life goes on, but there is a responsibility to continue to maintain and improve on their oral hygiene. We want to discuss the appropriate follow-up, our recall intervals, what the sanative schedule is going to be, and if there is going to be any need or replacement of any of the prosthetic components we've had. So for example, with a implant supported overdenture, the patient needs to understand that it's not something that is completed and lasts forever, but that there is a maintenance and the need to replace the retentive units for the attachments. We want to have well-informed patients that meet the full test of our consent to treatment. Here is a summary of the treatment plan, documentation of the treatment plan. We want to list the services that are to be performed. The patient should understand the relative urgencies of any particular treatment, and they need to understand the severity of their condition. For extended or complex treatment, we need to have a schedule, and the patient should understand how long the treatment is going to take, and a brief description of the services that will be performed at each appointment. It's very important that we document what needs to be monitored, and we schedule where in the treatment plan or at what appointment we're going to be following up on on whatever we are monitoring, and the patient needs to be informed of the importance of that follow-up. We also need to document the extent to which patient has accepted or rejected the recommended treatment plan. We need to document any recommendations for a referral and whether they've accepted the referral or declined. Ensure the patient understands the importance of the treatment and the need to involve a specialist, and it should be recorded in the chart. So now I'd like to turn things over to Kalyani, and she will begin with consent to treatment.
Thank you, Peter. Good evening, everyone. Thank you for taking the time for sharing your evening with us, precious times in the day. We are going to look at the other fundamental aspects of dental record keeping. And towards the end, I will also talk about certain unique aspects of electronic dental records from a security and confidentiality of personal health information perspective. We will also talk about retention and release of patient records. So let's start talking about consent to treatment. The most important thing to remember is there can be no treatment without consent. There is a lot of emphasis on consent to treatment. We have a standard of practice on consent to treatment. Our record keeping guideline has a dedicated section on consent to treatment. A lot of information on the college's website and frequently asked questions pertains to consent to treatment. So what is this consent to treatment? Simply put, it is both the law as well as a fundamental professional duty. Consent to treatment is grounded in the Healthcare Consent Act of 1996, which lays the legal framework for obtaining valid consent in Ontario. If you think about it, each one of us has been a patient at some point in time. As patients, we all want to know, and we have the right, the entitlement to understand what is happening to our bodies. That is the ethical principle of patient autonomy. Every individual has the right to decide what happens to their own body and decide to say no at any point in time. When we wear our healthcare practitioner hat as dentists, it is our responsibility to ensure that our patients are empowered to make that informed choice. It goes beyond compliance. It's about respecting the person in front of us and supporting them in making decisions that are right for them. So the first step in obtaining consent, valid consent, is to determine the patient's capacity. Patients are presumed capable unless determined otherwise. If a patient is deemed incapable, consent must be obtained from their substitute decision maker or SDM, and our standard on consent to treatment has greater detail on that topic. So what does it mean for the patient to be capable? A capable patient is one who understands all relevant information provided to them and the reasonably foreseeable consequences of choosing to proceed with or decline the proposed treatment. It is important to remember, though, that capacity is not static. A person may be capable with respect to providing consent for some treatments and not others. They may be capable at one point in time, but not at another time. This determination of capacity starts from any interaction. That's the first step with any interaction with the patient. If there is any uncertainty about the patient's capacity, it is prudent to reach out to the college's practice advisory service or contact the Consent and Capacity Board, CCB. Once we've determined capacity, there are some critical components to make sure the consent is obtained in an informed way. We will talk about the details of what informed consent looks like, but basically, It is making sure that a reasonable person in the patient's position has all the information they need to decide if they want to proceed with the treatment or not. It should also be treatment specific. And by that, what we mean is even if a patient may have signed a form for a comprehensive treatment plan, if that treatment plan includes different treatment procedures like veneers on anterior teeth and a root canal treatment on a posterior tooth, both those different treatment plans need to be need their dedicated informed consent discussions and documentation. It must be obtained voluntarily and not by coercion, and definitely not by misrepresentation or fraud. By that, we have to make sure we do not embellish certain outcomes or downplay certain risks in an attempt to convince our patients to accept treatments that we recommend to them as opposed to something that they want for themselves. There is an added nuance to consent. It can be implied consent or express consent. And implied consent is best illustrated with an example. If a patient has taken the initiative to book an appointment to see you, have arrived to the office, and are seated in the chair, of course, they have provided us implied consent to be assessed for their healthcare problems. For subsequent treatments that become more invasive, we have to make sure that direct, explicit, and unmistakable consent is obtained. For example, extractions, any other surgeries. All of those need express consent, and we will talk about the details. It can be given orally or in writing, but must be documented. In a nutshell, consent is an ongoing dialogue. It's an iterative process, not a single event where a patient signs a form with a list of long textual points which they may or may not understand. It must be an informed choice where we enable our patients to make decisions that are right for them, not what we think they should be doing. It must be current and specific and cannot be obtained retroactively. I cannot ask a patient to provide consent for an extraction that I may have done last week. So what does it take for consent to be informed? We have a list of certain criteria in the college's guidance documents as well. First and foremost, the nature of treatment, like Peter explained. We also, for example, if a patient is recommended to undergo root canal treatment, they may not understand what root canal means or how you're going to clean the inside of the tooth, or that they may need a crown after the root canal treatment is completed. We need to help the patient understand how that is going to benefit them. How is it going to resolve their pain or infection? Also, are there any material risks or material side effects? By material, we mean information that might influence an individual's decision. If that changes their decision, it is material. That said, every single risk does not have to be communicated. For example, if it is a very rare risk like paresthesia during an inferior alveolar nerve block, that's very rare. However, things that are more frequent, like separation of a file during root canal treatment, or if the risk of paresthesia, permanent paresthesia after extraction of a lower wisdom tooth, that's a very significant risk. So even if it is rare, that needs to be disclosed. If there are any other alternative courses of action, they must be explained to the patient. For example, while replacing a missing tooth, they can get implant treatment. Bridge and crowns are an option, or a removable partial denture. They need to be given all possible options. Also, they need to understand the consequences of not receiving the treatment. In addition to these 5 components, the college also expects us to inform the patient about costs. What's the cost of the root canal treatment, and is there a cost to the crown, and how much? Will there be costs to any other complications that might happen or are likely to happen? If procedures that are proposed to the patient are elective, the bar for informed consent is much higher, especially if patients understand that the strictly cosmetic procedures come with some significant risks. They are likely to decline those, and they need to be aware of that. We have a commonly asked question and that question is, how much documentation does the college require? The answer is, it depends. It depends on the procedure and sometimes on the situation. For a simple examination, the documentation does not have to be complex. A note in a progress note in the patient's chart can be adequate as long as it has all the elements. But as soon as treatment procedures start to become more invasive, more complicated, associated with higher risks, and are longer drawn out or have a higher cost, and especially if they are elective, the college recommends that we create solid, robust, well-drafted consent forms specific to those treatments. The college's website has some guidance on how to develop good consent forms. This is a nice handy checklist, which is on page 7 of the Standard of Practice, Consent to Treatment. It lists all the topics that we just covered, and it also adds a couple other items. When we document conversations around consent, if there are other people involved in that conversation, we need to make sure that is documented. And when consent is provided or not, it's important to note who was the person making that decision. Also, make sure any discussions or agreements concerning the anticipated costs of treatment are provided. That is one of the single most reasons for complaints received at the college, that patients were not aware of the costs involved. Did I mention the standard of practice on consent to treatment? This is what it looks like. It is very useful information, and it also has some embedded links to responses on the frequently asked questions for this topic. We also have a very nice and handy checklist on the website. I have downloaded it to my phone because it gives us information about our legal, ethical, and professional responsibilities at a glance. Now that we've obtained initial informed consent and treatment procedures are about to start, it is important to make sure that everything that happens during the clinical appointment is documented. This is where well-organized progress notes come in the picture because they help us stay organized, but also make everything defensible. Like Peter says, we need to show our work like we did back in math class. Let's take a minute to read this slide together. Progress notes should be well organized and legible. This is extremely important because if nobody can read our notes, it defeats the purpose. Many times, our records will be read by others. Patients have right to access copies of their entire patient record, but our records may also be requested by courts or by the college if an investigation is associated with any one of our patients. Or sometimes if there is interruption in patient care, another dentist should be able to pick up where we left and continue with the patient's care. Progress notes should also provide a clear and comprehensive description of the patient's ongoing care. Another important consideration is that they should indicate the reason for any treatment that is not readily apparent from the patient's history or documentation of the clinical and radiographic examination. I want to take this opportunity to share some of our observations and experiences here at the college. In my 10 years at the college, my colleagues and I have poured through thousands of patient records, and we find some common areas of missing notations or omissions in record keeping. Thanks to Peter, we've already understood some of those. I will quickly go through the list, but I also have an example to demonstrate. Diagnoses are often missed. It is a controlled act. Dentists have the authority to communicate a diagnosis, so we should make sure that we document them. If a patient is being provided a restoration, it's important to note if it is for caries or if it is for tooth wear. Same is true for materials and methods or details of a procedure. If we've taken the time to, say, give the patient 2 carpules of 2% lidocaine with 1:100,000 epinephrine, have given them an inferior alveolar nerve block with a long buccal infiltration, have checked with the patient if freezing is confirmed, and if we do not write it down, it might there is no indication that it happened. If we have taken an X-ray to determine working lengths, but that's not noted, again, it does not happen. So make sure that all the effort that we take in providing care to the patient is also documented. And it goes a long way in defending the procedures that we provide and perform for our patients' care. We talked a lot about discussions for informed consent. It is important to make sure that they are captured in our notes. This is something I'm guilty of myself, unclear abbreviations. This is a lot of documentation in dentistry, and it's tempting to use short forms, which is fine as long as they are standardized and they can be easily understood. But many times my colleagues and I have to send back letters to dentists saying, please explain these short forms to us. So try and make everyone's life easy, especially for your staff. The same is true for the location of pathology. We often see notes like rampant decay, but there isn't any information about which teeth are affected or which surfaces are affected. Another note is about professional language in the notes. Well, we have seen entries that read rude patient. It is okay to give ourselves reminders from a behavior management perspective, but maybe it's more appropriate to say what actually happened. Did the patient raise their voice? Or were they disrespectful towards staff? And another final observation to share is we often see submissions for predeterminations, but there is no note of clinical or diagnostic finding in the patient record. As we already talked about it, a busy practice has a lot of competing priorities. It is okay to get help from reliable, trained staff, but at the end of the day, it is the dentist's responsibility to review each entry and ensure that it captures the necessary information as soon as possible. The sooner we capture our notes and our procedures, the better it is. Let's take a look at this example. We will get to the text in the red box immediately, but I want to first draw your attention to the first 2 rows on this note. January 12, 2005, 21DL, 22MLDL. I'm assuming those are tooth numbers with some restorations, 2 surface restorations, but it's not clear if it was for caries or if it was a chipped tooth. The text 2 PAs is encircled, so radiographs were taken. We do not know which teeth were captured. We do not know what was observed, or was it within normal limits. So this is just an illustration of how difficult it can be to follow a treatment plan if it is not documented well. The next date January 28, shows RCT, which means a root canal treatment was probably provided, but there is no mention of whether local anesthetics were used, which ones were used, how many canals were found. Was there any other complication? Was there periapical periodontitis? We do not know. The list goes on. Let's look at the text in the red box. Finishing burr slipped, bruised right mandible, good patient. This note was provided to us by a patient who filed a complaint, and the next entry says, gave patient photocopy of chart. The patient also provided us this photograph. This is a pretty serious cut on the patient's face. What do we think? Is the documentation of this event in the patient's chart in compliance with our standards for documentation? The college's ICRC committee did not think it met the standard. The dentist did prescribe vitamin E, but it was not noted in the patient's chart. We are all human beings. Sometimes, despite our best efforts, adverse events can happen. But it is our responsibility to do our best to manage this situation and give our patients the best care to get better from that situation. In our series of checklists and lists for things to do, this is another one. We have a nice list of all items that should be captured on progress notes. It's page 9 of the dental record keeping guidelines. We've touched upon most of these, and I just want to remind you to make sure that all instructions are documented in the patient note, especially if they are associated with prescriptions or drugs that are either dispensed or administered to the patient. Any discussions with the patient regarding possible limitations of treatment or of problems encountered, complications, compromised results should all be included in the patient's notes. Let's look at another scenario that's common in most of our offices: patient referrals. Before we talk about the documentation, let's quickly look at reasons when a referral is appropriate or prudent. If it is difficult to arrive at a diagnosis, it's going to be difficult to prepare a good treatment plan for the patient. Also, if the case is beyond our expertise or experience, or if the patient has a very complicated medical history that the office may not be equipped to handle, or if despite all our best efforts, the patient's condition is not improving, or even if we have the expertise and the equipment based on our informed consent conversations, if we understand that the patient's expectations exceeds the potential outcomes, all of these scenarios, it would be prudent to refer them to a specialist or another provider who we think can help the patient better. When it comes to documentation, the college has a practice advisory dedicated to this particular scenario. It's called the most responsible dentist. And that's because generally the general dentist is the primary treatment coordinator or the most responsible dentist. The advisory outlines responsibilities of both the dentist who's providing the referral and the dentist who the referral has been made to. Before we talk about the aspects of documentation, it is important to know that it is the most responsible dentist's responsibility to be familiar with credentials of all dentists to whom our patients are referred, and even if we are referring patients to other healthcare providers. When it comes to dentists practicing in Ontario, the college's website has a feature, Find a Dentist. All dentists licensed to practice in Ontario are registered, and you can search them up by practice, location, by specialty, and you can also look up their educational history. or professional history with the college. And it is helpful for us to make sure that our patients are being sent to the right provider. Documentation, of course, is important because not only does it maintain continuity and good quality of patient care, it also helps us build trust with our patients and our colleagues. Before we start documenting, it is important to have a conversation. Just like we did for informed consent, patients need to understand what is the expectation from this referral, the reason for the referral, also the nature and scope of the referral. If the patient is being sent to a surgeon only for the surgical placement of an implant, but they're going to come back to you for the restoration of the implant, the patient needs to understand the scope and nature of that referral, and also what are their anticipated outcomes. Make sure we set reasonable expectations for our patients. It is very common that the other provider or specialist may have to conduct additional tests, obtain additional records, so treatment may not start on the very first appointment, or there may be additional costs, or both. So that information must be provided to the patient. We already talked about the need to understand credentials of the patients to whom we are referring our patients. And if there is a need to come back to the general dentist, make sure that is emphasized. In addition to all those discussions and notes, it is also important to make sure that copies of any correspondence or reports to and from the referral dentist are maintained in the patient chart. The reason for saying communication 3 times on this slide is because we want to say that it cannot be overemphasized. Therefore, as much documentation, so written and oral communication are important. Despite all our efforts, if a patient does not want to proceed with the referral, let's document the informed refusal and make sure that the notes capture any needs for follow-up. If they're going to a periodontist, do they need to go back for follow-up? And who is responsible for what part of the patient's care? This is another list in our series of helpful checklists. It's on page 10 of the Dental Record Keeping Guideline and has identified all elements for documentation of a referral. The most important thing to remember is consent. Consent must be obtained before sending any information to another dentist or discussing the patient's conditions or treatment needs with a third party. Now that we've talked about referrals, let's delve into the world of electronic records. Electronic records are the norm rather than the exception these days, and they come with some added considerations or risks for safety and security of personal health information. The first item on our slide, the left-hand side, says physical access controls. What that means is the physical device, our computers, laptops, servers, should not be in areas that are accessible to the public. Making sure that they are secured is important. They are very precious. The next item is logical access controls or role-based access, which means only people who have the authority or need to make changes or entries or access the patient record are given logical access or login credentials or passwords to our software devices. And one way to also help with controlling logical access is audit and accountability controls. What that means is there's a thing called audit trails. It's important to check with the vendor that they have set up strong audit trails because these trails document all activities in a given operating system or software. We need to be able to understand who accessed our records and when. It may not be easy to identify a change ourselves by looking at the record, but the audit trail captures all of it. Also, it may be useful to identify any malware, invasion by computer software. So strong audit trails are important and make sure our vendor has set them up for us. By data in motion, we mean transfer of information through electronic channels and media. It is very common for patients to communicate with us via email or other social media platforms, and they might even request us to send records via email. The Information and Privacy Commissioner has stated very clearly that personal health information cannot be sent without strong encryption. Thankfully, the Canadian Dental Association has a secure send platform that we can use, and there are other products in the market as well. The next item is backup and contingency planning. Most people are aware with this concept. We all try and back up our phones, for example. Same thing with our softwares for patient data. Especially if our vendor says backup happens every day, it's important to make sure that it does happen. So if that server goes down, we have a contingency plan in place. What do we mean by data migration? Sometimes there might be newer products in the market. So you want to replace your existing software with the new software that has more features. Before making the purchase, it is important to ensure that all the information and data in the old software will be migrated successfully without any loss to the newer software. Last but not the least is retention and disposal of patient data. After the required retention period is over, we would have to destroy the patient records, but in electronic records, they may be saved in more than one location. The computer in your office, but also a software, also another server, I meant. And sometimes there might be copies on USB keys. All of those need to be raised when it's time to destroy the patient records that are no longer needed, and they have passed the required retention period. The college has guidelines on the duration of retention of dental records, which is 10 years from the date of the last entry. And it's important to note that it says date of last entry. So if the last appointment is today, but we expect to receive information from a specialist a month from now, the 10-year clock starts after that referral has been received. For minors, it's 10 years from the date when the patient reaches the age of 18 years. This 10-year rule applies to all clinical and financial records, administrative records, and diagnostic or study models. There are two exceptions. If we have working models, they may not be necessarily retained for 10 years. It's up to the discretion of the dentist. The minimum is 2 years. But if you want to keep them beyond that, that's to your discretion and judgment. Also, claims submitted for insurance purposes need to be retained for 2 years. And after that, it's up to your discretion. A commonly asked question to the college's practice advisory is, which format should the records be retained in? And the scenario that's around those questions is mostly that the office prints medical or dental history forms for the patient to fill out, but then they're scanned for convenience. In this case, the original is the paper record, and that's the format the record must be retained for the 10 years. Once the retention period has passed, the records can be destroyed, like we just talked, but with due attention to the patient's confidentiality, the confidentiality of patient information. This is a legal and professional requirements because patients have a right to copies of their records. And even if the account is not paid, we do not have the right to deny access to their records. We must comply with the request for records and in a timely fashion. 1 to 2 weeks is acceptable. Patients only have a right to the copies because as custodians, we need to retain the originals. It's important to again note that we have right consents. Sometimes patients' representatives may ask for records, and it is important to make sure that the representative has the right consents before we give them any records. I want to take a moment to talk about certain situations when there is sudden interruptions in practice, especially if there is the unfortunate event of the passing of a dentist. In those situations, the estate trustee or the person who has assumed responsibility for the administration of the deceased dentist estate assumes responsibility for retaining the dental records until they can be transferred to another dentist. The Information and Privacy Commissioner has produced some documents to help us in our compliance with the Personal Health Information and Protection Act, PHIPAA. The first document talks about how to avoid abandoned records, some guidelines towards that. And there is also a checklist for health information custodians in the event of a planned or unforeseen change in practice. We may get requests from the police or the coroner's office for releasing records of deceased or missing individuals. It is called their authority to seize information for an investigation. We need to comply with those. The image on the right-hand side is what the form looks like. Sometimes family members may make those requests. Again, it is important to make sure they have the authority to obtain those records. Some key messages as we wrap up. We're almost there. Make sure that we remember that a patient has a right of access and may request a copy of any record at any time, and we cannot deny them that right. Also, it is important to be objective, professional, factual, and verifiable in all documentation. And here's a visual to help with that. We can look at our records from a retrospective angle. For example, if a patient has complained to the college about a particular treatment and they have concerns, then the investigator at the college might look at the treatment provided and then assess if the treatment plan, examination and diagnosis and history align with that procedure. Or when submitting a predetermination to insurance, they might want to know from a prospective angle what your next plans are. What do you plan to provide? Is there going to be a crown after that root canal treatment? So that's the prospective take on our records. We've gone through a lot of information in this short period of time. Please make sure that you review the resources. But for now, let's take a moment. Given what I have learned today, what is one thing I will do to strengthen my documentation in the patient record? It applies to me too, even in my work at the college. We have lots of useful resources on the college's website. It is really a virtual buffet of standards, guidelines, advisories, and not to mention checklists for consent to treatment, also sample questionnaires for histories and other tools. You can scan this QR code and get access to the website. And there's also the opportunity to find other resources on the website. We have this newly launched web page, Professional Practice Resources. It is nicely sandwiched between the Standards and Guidance tab and the Permits and Renewals tab. So we are constantly striving to provide resources that help all of us provide safe patient care. New courses are being developed in consultation and collaboration with the faculties of dentistry. Please take a moment to review the offerings, and hopefully they are included in your continuing education plans. You can always contact the college's practice advisory service. This is their email address and phone number. We've come towards the end. Thank you so much for your time. Over to our registrar, Mr. Faulkner, for closing remarks.
Oh, thank you so much, Dr. Baldota, and thank you, Dr. Baldota and Dr. McDermott, for such a great session this evening. I just want to express how much we appreciate you taking the time out of your, I know, very busy schedules and sharing your expertise and insights with us today. You have demonstrated that you have deep knowledge of record keeping and documentation and quality improvement, and this has been so invaluable to everyone who has joined this evening. So we're really grateful for your ongoing contributions to the college and to the profession. I can say that we were at a level of 2,500 or more attendees this evening. And as I looked at some of the Q&A, our staff were able to answer more than 130 questions, and that may have even gone up within the last few minutes since I looked at it. I want to also thank everyone who joined us this evening. Just as a reminder, you do not need to take any action to receive your Category 1 CE certificate. We will use the Zoom attendance records and email certificates within 5 business days. As we close today's session, I encourage you to continue exploring this topic. Record keeping is a cornerstone of safe, ethical, and accountable patient care. And staying current with the college's expectations supports both professional excellence and the public interest. Today's session was really intended as an introduction. To learn more, we encourage you to consider our fundamentals and applied courses in record keeping, as well as the other foundational courses listed on the professional practice resources section on our website. This dedicated area brings together practical toolkits, guidance documents, and information on upcoming Category 1 courses. We've shared the link in the chat. You saw some of those resources from Dr. Baldota, and I encourage you to explore it and bookmark it for your future reference. If you have any practice-related questions, whether about documentation, consent, privacy, or clinical decision-making, our practice advisory service is always here to help you. You can reach that team at practiceadvisory@rcdso.org, or you can call at 1-800-565-4591. I also encourage you to follow the college on social media for updates, new resources, and information on upcoming RCDSO Connect sessions. We hope you'll join us at future RCDSO Connect sessions, and registration for the next one on March 11th will begin this week. So thank you again to our presenters. Thank you again to everyone for joining us, and please enjoy the rest of your evening.